Imagine for a moment you're heading into what seems like a routine surgery, maybe something pretty minor. But silently, expertly, there's this tiny electronic device doing critical work inside your chest, keeping your heart beating rhythmically, or maybe it's just sitting there, poised to deliver a life-saving shock if needed. Now, think about the operating room itself. All those powerful instruments, things like electroceutical tools, buzzing with energy. How do the medical professionals make sure you're safe when the very instruments they need to use could potentially interfere with that delicate device? Maybe alter its function or, I don't know, even damage it. It's like this silent, intricate dance between cutting edge tech and, well, deep human expertise.
It truly is. A silent dance is a great way to put it. And that dance, that really complex interplay, that's exactly what we're diving deep into today. We're talking about cardiac implantable electronic devices, or CIEDs for short. As our population ages and more people are living longer with various heart conditions, these devices are becoming incredibly common. So their expert management isn't just important anymore, it's frankly absolutely critical in modern healthcare.
And while this deep dive is definitely aimed at giving you the kind of insights the elite professionals in this field have, it's really not just for people in the medical profession. Understanding these devices, their history, how they actually work in detail, the incredible precision needed to manage them, it gives you a profound appreciation for the teamwork and honestly, the constant adaptation that's just central to patient care today. Our mission here is to really master this information, just like the experts do. We're going to unpack the complexities of CIEs, looking at their origins, the modern advancements, their detailed functions, and most importantly, how they're managed safely, especially during surgery, where that electromagnetic interference, EMI, is such a significant threat. We're definitely going beyond just the surface level stuff to give you a truly informed perspective.
Absolutely. And to truly master this, let's start right at the foundation. What exactly are CIEDs, and why are we seeing so many more of them now? You touched on it already, but that demographic shift in the U.S., the increasing mean age, well, it means we're seeing more older patients, and many of these older patients have associated cardiac pathology, heart issues. So this directly leads to an increasing need for CIEDs. It just makes sense. As a result, a lot of patients coming in for surgery or any kind of procedure today will likely have one of these devices already inside them.
Okay, so we're talking about a significant group of patients, and it's growing. But when we say CIE, that's not just one thing, is it? It sounds like a whole family of devices.
Precisely. It's definitely a spectrum. CIEDs broadly fall into several main categories. The original, and maybe the one people think of first, are pacemakers, or PMs. Then you have implantable cardioverter defibrillators, ICDs, which came along a bit later, designed for a different, faster heart rhythm problem. What's really common now are combination devices. These cleverly put together both the pacemaker and the ICD functions into one unit. And finally, there are cardiac resynchronization devices, sometimes called biventricular devices, which are used for specific types of heart failure. And honestly, the sheer speed of tech advances means there's enormous variability across all these devices. Plus, new clinical applications are popping up constantly.
That rapid evolution sounds like, a double-edged sword. Great for patients, obviously, but a huge challenge for the healthcare team trying to stay on top of it all.
It absolutely is. And that brings us right to the core challenge, probably the biggest hurdle in managing these devices. Electromagnetic interference, EMI. Think of EMI as basically any external non-biological electrical signal that could potentially interfere with how a CID is supposed to function. During surgery, that intraoperative EMI, especially from things like electrocautery, can actually alter, disrupt, or even damage these incredibly delicate devices. A major problem, especially for those striving for elite professional knowledge, is that the technology changes so fast. There's often a real lack of solid evidence-based practice guidelines and even troubleshooting methods that can truly keep pace.
Yeah.
This knowledge gap is a really critical point, and it significantly complicates how these devices are managed day to day.
So the big takeaway here, the thing you absolutely have to remember is that you just cannot make generalizations about CIEs. You really need to know the specifics for each patient, each device, because what works for one might actually be dangerous for another.
Exactly. That's spot on. To truly master patient safety in this area, it is absolutely paramount to have specific knowledge about that particular device. This includes knowing its exact type, why it was put in, who made it, its basic functions, how it can be programmed, its battery life, crucially, how it responds to a magnet, and any inherent limitations it might have. Without that level of detailed understanding, you're essentially navigating blind in a pretty high-stakes environment. So our deep dive today will give you a thorough review of CIEs, detail the multidisciplinary team's responsibility in managing them, explain how CIEs might react to EMI, and really importantly, outline intraoperative management strategies for the various types of CIEs.
All right, let's dive into pacemakers first then. They've been around for quite a while, providing those life-saving beats for decades now. What's their origin story? How did they come about?
Yeah, pacemakers actually emerged about 70 years ago. They were born out of a really critical need to save patients who were suffering from sinus node dysfunction or atrioventricular node dysfunction. Basically, situations where the heart's natural electrical system wasn't initiating beats properly or wasn't conducting them effectively. Those early pacemakers, though, were quite primitive compared to today and pretty invasive to implant. They were initially placed via thoracotomy, which is, a major open chest surgery.
Wow, that sounds like a massive undertaking for something that's, well, relatively common today. What were those early devices actually like in terms of function?
Oh, very limited. Imagine a device that could only pace the ventricle and only at a constant fixed rate. And crucially, they completely lacked any sensing capabilities. They couldn't listen to the heart's own intrinsic activity at all. This, as you can imagine, led to a whole host of problems. Lead fractures were common, the electrical thresholds needed to make the heartbeat would randomly change. There was often competition between the heart's own rhythm and the pacemaker's relentless rate, and they were highly susceptible to electromagnetic interference. It was definitely a step forward, but it came with significant caveats.
So lots of issues that needed ironing out. What was the big breakthrough? What really changed the game and made pacemakers genuinely reliable?
That breakthrough, the real game changer, was the creation of the reed switch. This was a truly revolutionary innovation. It allowed the pacemaker to convert from synchronous pacing, where it tries to work with the heart's rhythm, to asynchronous pacing, where it just paces at a fixed rate. And it could do this simply with the application of a magnet. That was a massive leap forward.
How does something seemingly so simple, like a magnet, trigger such a complex internal change in this tiny device?
It's quite ingenious, really. The reed switch itself is made of two tiny magnetic metal strips, housed right within the pacemaker's pulse generator. When a magnetic field is present, like when you place a magnet directly over the pacemaker, these two little metal strips physically touch, closing the reed switch. This action, in turn, inactivates the sensing circuit. It stops the listening function. This change in voltage is precisely what causes the pacemaker to switch modes and start asynchronously pacing the myocardium, the heart muscle. This invention truly revolutionized pacemaker technology and firmly secured their place as a safe and reliable intervention for patients with slow heart rhythms or conduction blocks.
That is genuinely ingenious. The simplicity of using a magnet for such a precise internal change. It makes you wonder how they even thought of that back then. Was it like an accident or a specific design goal? Anyway, let's jump to modern pacemakers. What do they look like now and how are they put in today?
Right, so today's pacemakers are incredibly miniaturized, often no larger than a quarter, maybe a bit thicker. They basically consist of two main components. First, you got the pulse generator. That's the brain of the device, housing the battery, all the complex circuitry, and the connectors for the leads. Second, you have the insulated lead wires. These are like the electrical highways conducting energy to the heart muscle, the myocardium, and also carrying signals back from the heart. The pulse generator itself is usually implanted in what's called a pectoral pocket, typically on either the right or left side of the chest, just under the skin and muscle. And the procedure itself, much less invasive now. It's usually done while the patient receives either a general anesthetic or just a local anesthetic with some sedation, a world away from those early thoracotomies.
And how do these modern pacemakers listen to the heart? That sensing capability sounds absolutely critical to making them work smartly.
It is arguably their most crucial feature. Inside that pulse generator is a sophisticated sensing circuit. This circuit is designed to pick up the heart's own electrical signals, which are transferred from the myocardium back up through the leads. The pacemaker then interprets these signals. A high-amplitude signal is correctly seen as intrinsic cardiac activity, meaning the heart is beating fine on its own. A low-amplitude signal, however, is often interpreted as interference, what we commonly call noise. The device is engineered with filters to screen out these low-amplitude signals, ensuring it primarily senses the native cardiac signals. This allows the pacemaker to correctly interpret what the heart is doing intrinsically and initiate pacing appropriately, but only when the heart actually needs that support.
So it's like the pacemaker has these really sophisticated ears tuned specifically to hear the heart's actual beat. But sometimes, even with good ears, you can mistake static for the real thing, right? Does that mean it's still vulnerable to EMI, that interference?
Unfortunately, yes. Even with all that sophisticated filtering, in the presence of strong electromagnetic interference, this noise can still fool the pacemaker. It can cause the device to inaccurately sense what it thinks is intrinsic cardiac activity. This inaccurate sensing, this oversensing, often results in the pacemaker inhibiting its pacing function. It holds back when it shouldn't. Now, for a patient who is completely dependent on their pacemaker to maintain a heartbeat, this inhibition can lead to a dangerous loss of mechanical cardiac activity. It can be life-threatening if no underlying escape rhythm kicks in. That's the real danger zone.
And what about the wires themselves, the leads? You mentioned different configurations, unipolar versus bipolar. Does that distinction affect the risk from EMI?
It absolutely does, and understanding this is really key to appreciating how these devices are designed for safety. A pacemaker might have up to 3 lead wires, and these can be strategically embedded into various heart chambers, the right atrium, the right ventricle, sometimes both, or even the right atrium and both ventricles in more complex setups for resynchronization therapy. These lead systems can be configured as either unipolar or bipolar.
Okay, let's break down that difference. Unipolar versus bipolar. How does that impact the EMI risk specifically?
Right. In a unipolar configuration, the pulse generator itself, the CAN, acts as the anode, the positive electrode. The distal tip of the lead wire acts as the cathode, the negative electrode. The crucial point here is the greater distance between these two poles. The electrical circuit is much larger. This increased distance means unipolar leads inherently have a higher risk for electromagnetic interference because essentially they create a larger antenna that can pick up stray electrical currents. Clinically, on a surface ECG, the electrical spikes, those little vertical lines showing the pacemaker firing, are often noticeably larger with unipolar leads. That can be a visual clue.
Okay, so longer distance, bigger antenna, higher risk. Makes sense. What about bipolar then?
Bipolar leads are different. They contain 2 electrodes, but in this setup, both the anode and the cathode are located right near the distal tip of the lead wire itself. As a result, there's a much shorter distance between the 2 poles. The circuit is tiny and localized. This significantly decreases the chance of picking up EMI and substantially reduces the potential for disruption to the pacemaker's function. You can sometimes spot bipolar electrodes on a chest X-ray. They often have a distinctive distal ring located just a centimeter or 2 from the very tip of the lead. And because of this inherent safety advantage, most modern pacemaker leads are indeed bipolar. They also tend to exhibit smaller, less prominent spikes on the surface ECG.
That makes perfect sense. Smaller area, less chance for interference. But does that mean bipolar is completely immune, or are there still, subtle risks we need to be aware of? Regardless, when we're looking at an ECG, how can we actually tell what the pacemaker is actively doing inside the heart?
Well, while bipolar leads significantly reduce the risk, no system is entirely foolproof, especially with strong EMI sources. That's why vigilant monitoring is always essential. As for the ECG, pacemakers have distinct sensing and capturing responses that show up as specific spikes. For instance, if the pacemaker lead is only in the right atrium, you'll typically see a small spike right before the P wave on the ECG. That represents the atrial depolarization triggered by the pace. If the lead is in the right ventricle, you'll see a spike immediately followed by a QRS complex, indicating the ventricular depolarization. And if it's a dual-chamber pacemaker, with leads in both the right atrium and ventricle, you'll see 2 spikes, one before the P-wave AD, another one before the QRS complex, followed by both atrial and ventricular depolarization. Now, importantly, if the device is simply sensing the patient's own intrinsic rhythm and not needing to pace because the heart's natural activity is sufficient, you'll only see a little sensing marker on the ECG tracing without a pacing spike. That tells you the heart's doing its own thing and the pacemaker is correctly standing back.
So these are the visual cues, the language of the ECG, giving clinicians that real-time window into the device's function. What are the common reasons, the conditions, that lead to someone needing a pacemaker in the first place? Why do people get them?
Right, the why. Pacemakers are primarily needed when the heart's natural electrical system isn't reliably generating beats or conducting them properly. While there's a whole list of specific indications, the core idea is that these devices step in for abnormally slow heart rhythms, bradycardias, or significant conduction blocks. Common reasons include things like sinus node dysfunction, where the heart's natural pacemaker, the sinus node, just isn't firing fast enough, causing very slow heartbeats, or atrioventricular AD node disease, where the electrical signals get slowed or blocked between the atria and the ventricles, leading to slow or irregular ventricular rates. Other key indications are things like chronic bifascicular block, which is a pretty severe conduction problem in the ventricles, certain types of long QT syndrome, and even some heart muscle conditions like hypertrophic obstructive cardiomyopathy or dilated cardiomyopathy, where pacing can actually help improve the heart's mechanical function. They're also sometimes placed after a significant myocardial infarction, a heart attack, if the electrical system gets damaged. Or for conditions like carotid sinus syndrome, which can cause fainting spells due to an overactive nerve reflex, slowing the heart dramatically.
You've been focusing mainly on the implantable pacemakers, the long-term ones. Are there other types, maybe ones used in emergencies or for temporary situations?
Yes, absolutely. While our deep dive today is centered on the implantable devices, it's really important for any professional aiming for mastery in this area to know that various types of external pacemakers are also available and used frequently. The key difference: these external devices can be manipulated manually right there, right then, if a disruption in pacing occurs. They offer direct, immediate control. An implantable pacemaker, on the other hand, requires specialized reprogramming using a specific device programmer or, in some very specific scenarios we'll discuss, the precise application of a magnet to fix unreliable or disrupted pacing behavior. You can't just tweak a dial on the outside.
Okay, can you quickly run through those external types just so we have the full picture?
Sure. First, there's transcutaneous pacing. This is often the go-to in emergencies. You apply large pacing pads directly onto the patient's skin, usually either one on the right upper chest and one on the left lower chest, or sometimes one on the front mid-chest and one on the back between the shoulder blades. These pads then get plugged into a defibrillator or a dedicated pacing machine, and you program the rate and output right there. Second, there's transvenous pacing. This is a more invasive temporary solution. A special pacing catheter is carefully threaded into the central circulation, usually through a large vein via an introducer sheath, and then positioned inside the appropriate heart chamber or chambers. This pacing lead is then connected to an external pacemaker generator box and again programmed as needed. And third, we have epicardial pacing. You often see this after open heart surgery. The cardiac surgeon actually sews thin pacing wires directly onto the surface of the heart, the epicardium. These wires are then brought out through the skin, attached to an external pacing device, and programmed according to the patient's clinical situation post-surgery.
Okay, so with those external devices, if something goes wrong, say, it stops capturing of the setting, you can just immediately adjust the settings manually. But with the implantable ones, it's a whole different ballgame, much more complex to troubleshoot on the spot.
Exactly. That's the crucial difference in management. With a non-implantable external device, a clinician can spot a problem. Maybe failure to capture, failure to sense, and intervene immediately just by manipulating the programming on the external box. Manually changing the heart rate, cranking up the electrical output to get capture back, adjusting sensitivity. But with an implantable pacemaker, that kind of direct on-the-fly adjustment just isn't an option without access to that very specific manufacturer-specific programmer. Troubleshooting an implantable pacemaker requires sharp problem recognition, knowing if the device is supposed to respond to a magnet, and crucially having physical access to that programmer to make any changes at all. This really highlights the importance of that multidisciplinary team approach, and pre-planning we'll get into later.
That leads perfectly into what sounds like a critical piece of language for clinicians dealing with pacemakers, the HRS codes.
Oh, absolutely imperative. The Heart Rhythm Society, HRS, developed a precise 3- or 5-letter code that identifies the key functions of implantable pacemakers. For any healthcare provider involved in managing these patients, it's not just about being familiar with these codes. To truly master this, you need to understand the codes deeply and know the functionality and the resulting behavior of the pacemaker based on that code.
Okay, let's break down this code then, position by position. We need to really nail this for understanding patient safety. What does that first letter tell us?
Right, the first letter in the HRS code identifies the chamber or chambers being paced. A means the atrium is being paced. V means the ventricle is paced. D stands for dual, meaning both the atrium and the ventricle are being paced. And O means no chamber is being paced by the device in that mode. So this tells you where the pacemaker is delivering its electrical stimulus.
Simple enough. What about the second letter?
The second letter identifies the chamber, or chambers being sensed. Where's the pacemaker listening? Again, A means sensing is happening in the atrium. V means sensing is in the ventricle. D stands for dual sensing in both chambers. And if the second letter is O, it means there's no sensing at all. In this case, the pacemaker operates in an asynchronous mode, pacing completely independently of whatever the heart's intrinsic rhythm might be doing.
Got it. Paced, sensed. Now the third letter, that sounds like where the logic comes in, how the device actually reacts to what it senses.
Exactly. This is where the intelligence, the programmed response of the pacemaker really comes into play. The third letter defines the pacemaker's response to sensing a spontaneous cardiac depolarization. It dictates what the pacemaker does next. Essentially, the device will either inhibit its output or trigger a pacing stimulus based on what it senses. If the third letter is I for inhibited, the pacemaker's output is withheld. It doesn't pace if the intrinsic sensed activity is faster than the programmed lower rate limit. Basically, it steps back if the heart is beating fast enough on its own. If the third letter is T for triggered, which is typically used in single-chamber modes, the pacemaker actually delivers a scheduled output pulse in response to sensed intrinsic activity. This mode is often used for specific diagnostic tests or electrophysiology studies, less common clinically day-to-day. If it's D for dual, T plus I, the pacemaker has the capability to either inhibit or trigger in response to sensed intrinsic activity. A classic example is a sensed intrinsic atrial beat might inhibit the atrial pacing output, but then trigger a timely ventricular pacing output to maintain AV synchrony. And again, an O in this third position means there's no specific response to sensing, because there's no sensing. The pacemaker simply provides asynchronous pacing. Understanding these first three positions, paced, sensed, response, is truly foundational for anyone managing these devices professionally.
So it really comes down to how smart the pacemaker is programmed to be in interacting with the heart's natural rhythm, or sometimes choosing not to interact and just taking over. You mentioned there are sometimes fourth and fifth positions in the code. For our deep dive today, really mastering those first three gives us the most powerful insight into the pacemaker's core function, right?
Absolutely. For really understanding the fundamental behavior in most clinical scenarios, mastering those first three letters is key. Just quickly, the fourth letter, if present, is usually R, and that indicates rate modulation capability. This means the pacemaker has a sensor, maybe detecting motion or breathing, that allows it to adapt its pacing rate to the patient's physiological needs, like speeding up the heart rate during exercise. Very clever stuff. The fifth letter deals with multi-site pacing. This indicates if multiple locations, say in both ventricles or both atria, are being paced simultaneously for specialized therapy, like cardiac resynchronization therapy for heart failure. These are definitely important advanced features, but those first three positions, paced, sensed, response, dictate the absolute fundamental pacing and sensing behavior we need to grasp firmly.
That's a lot of specialized terminology to get straight. Can we quickly run through some of the absolute key pacemaker vocabulary, like a quick reference glossary to make sure we're all speaking the same language, aiming for that elite professional level of understanding?
Good idea. Yeah, these are the terms you'll hear and need to use constantly. When we talk about heart rate in the context of a pacemaker, we mean the programmed upper and lower heart rate limits the device will maintain or allow. Electrical output is the amount of electrical energy the pacemaker delivers with each pacing pulse, and it's measured in milliamps, or mA. Synchronous mode means the pacemaker is trying to work with the heart, timing its pacing relative to the underlying rate of one of the heart chambers it's sensing. Conversely, asynchronous mode is when the cardiac pacing is set completely independent of the heart's intrinsic rate. It just paces at a fixed rate no matter what the heart is doing, like DOO or VOO modes.
And what about those terms related to how it interacts with the heart's own beats?
Right. Inhibited is key. When the patient demonstrates their own intrinsic heartbeat that's fast enough, the pacemaker inhibits its output. It will not deliver a paced beat. Threshold is a critical concept. It's the absolute minimum electrical output in MA that will consistently cause the targeted heart chamber, the atrium, or ventricle to contract or capture. We need to make sure the output is set safely above this threshold. Sensitivity is about how well the pacemaker hears. It's the lowest amplitude electrical signal, a P wave or R wave, that the pacemaker will recognize as a legitimate intrinsic electrical signal, measured in millivolts and MV. The AV interval, or AV delay, is the programmed time delay between the beginning of atrial activity, whether it's paced or intrinsic, and the beginning of ventricular pacing. It mimics the natural PR interval on an ECG and helps maintain that atrial kick.
And what about when things don't work as intended? Failure modes.
Yeah, critical terms here too. Capture refers to the successful depolarization of a heart chamber in response to the pacemaker's electrical output. You see the spike, and then you see the heart respond, P wave or QRS. If the pacemaker fires, you see the spike, but the heart muscle doesn't respond. That's failure to capture. The output wasn't enough, or there's a problem with the lead or tissue. And if the pacemaker fails to recognize the heart's own intrinsic electrical activity when it should, essentially, it's not hearing properly. Maybe the sensitivity is set wrong, that's failure to sense. This can lead to pacing when it's not needed, which can be problematic. These terms capture, threshold, sensitivity, failure to capture, failure to sense are absolutely critical for accurately diagnosing and troubleshooting pacemaker problems in any clinical setting.
Okay, fantastic. We've really dissected pacemakers, their history, anatomy, those crucial codes, the key vocabulary. Now let's shift gears to their, well, more powerful relatives. Implantable cardioverter defibrillators, or ICDs. How do they fit into the bigger picture of managing heart rhythms, especially when things get really fast and dangerous?
Yeah, it's a natural progression in our discussion. We move from pacemakers, which primarily handle the slow heart rhythms, the broad arrhythmias, to their even more powerful relatives, the ICDs. While those symptomatic slow rhythms are treated with pacemakers, the fast, often chaotic, and potentially lethal heart rhythms, the tachyarrhythmias, are frequently managed with an ICD. An ICD serves as a highly reliable, truly life-saving method to restore a regular, coordinated rhythm when the heart goes into a dangerous tachyarrhythmia. It literally shocks the heart back into a safe beat when it's in crisis mode.
And just like pacemakers, ICDs must have evolved significantly since they were first introduced. I can only imagine how bulky and, frankly, primitive those first models must have been.
Oh, absolutely. The evolution has been dramatic. There have been incredible technological advancements in recent years that have profoundly improved their effectiveness and made them far, far less invasive to implant. The very first ICVs, developed back in the 1980s, were indeed quite primitive by today's standards. They ran on simple batteries and required major open chest surgery, either a thoracotomy or a sternotomy, just to place the components. The defibrillation energy was delivered through large patches that were actually positioned directly onto the surface of the heart, the epicardium, and the lead wires. They were then tunneled all the way down to the patient's abdomen, which is where the much larger defibrillator generator box was housed. Plus, these early devices had very limited programming capabilities. When a shock was needed, the battery sent energy to a capacitor, which, once it was fully charged, rapidly discharged that energy through the wire to the heart muscle, delivering the shock. By the 1990s, things improved. The generator was still often implanted in the abdomen, but the bulky epicardial patches were replaced by ICD lead shock coils. These could be inserted through veins, transvenous access, and implanted inside the right ventricle. That was a huge step forward in reducing surgical invasiveness.
So, getting less invasive, but still a pretty elaborate setup with that abdominal generator. What do modern ICDs look like today? How do they function as these guardians against lethal rhythms?
Today's ICDs are much more integrated and compact. They essentially consist of a pulse generator, a high-capacity battery, a voltage capacitor, a lead wire, and a shock coil, all designed as one single relatively small unit. The generator itself is now most often implanted in that pectoral pocket, just like a pacemaker, on either side of the chest. Again, usually done under general or local anesthetic with sedation, a much simpler procedure. The ICD lead, which includes the shock coil, is attached to this pulse generator and then strategically positioned, typically within the right atrium and around right ventricle. That capacitor is still the critical component for delivering the shock. It rapidly receives energy from the generator's battery and then discharges this energy as a powerful electrical impulse when needed. This impulse travels instantly through the lead shock coil directly to the heart muscle, expertly cardioverting or defibrillating the heart to treat that dangerous tachyarrhythmia.
And you mentioned earlier, modern ICDs aren't just about shock therapy anymore, right? They often pull double duty.
That's absolutely correct. While the original ICDs were purely for delivering antitachycardia therapy, the shocks, virtually all modern ICDs, are dual-function devices. They also contain sophisticated backup pacing capabilities. They essentially combine the life-saving shock functionality of an ICD with the rhythm-regulating features of a pacemaker, all in one device. So for our deep dive today, and for most clinical practice now, our discussion will primarily focus on these incredibly versatile dual-function ICDs. They're the standard of care.
Right, truly a two-in-one device then, handling both the fast and the slow problems. How are they programmed to actually accomplish these multiple complex jobs?
They have incredibly sophisticated programming options. Modern ICDs can be programmed to accomplish a whole array of interventions. For example, a lead shock coil placed in the right atrium isn't just for sensing. It can be programmed to treat bradycardia through pacing and sensing, provide rate modulation to adjust the heart rate based on activity, initiate special antitachycardia pacing sequences to try and stop fast atrial rhythms without a shock, and even cardiovert certain atrial arrhythmias if programmed to do so. Similarly, a lead shock coil placed in the right ventricle can, of course, treat dangerous ventricular arrhythmias like VT and VF with shocks, but it can also initiate antitachycardia pacing in the ventricle, cardiovert VT, defibrillate VF, and treat bradycardia through pacing and sensing if the heart rate drops too low after a shock or otherwise.
And if the device is one of those specialized cardiac resynchronization therapy defibrillators, CRTD, there's an additional lead wire carefully threaded backward, retrograde, through the coronary sinus vein system to reach the outer wall of the left ventricle. This allows for synchronized pacing of both ventricles, specifically for certain types of heart failure.
Just like with pacemakers, there must be very specific reasons, very clear indications for putting in an ICD. What are the main life-threatening conditions that really warrant an ICD?
Indeed. The indications for ICDs are really centered around preventing sudden cardiac death from those lethal fast rhythms. Key indications include patients who have survived ventricular tachycardia, VT, or a ventricular fibrillation, VFF. Those are primary prevention scenarios. Other major indications are for patients who've had a significant myocardial infarction but are left with a very low ejection fraction, usually less than 35%, indicating severe heart muscle damage and high arrhythmia risk, even if they haven't had VT or VF yet. This is secondary prevention. Similarly, cardiomyopathy or heart muscle disease from pretty much any cause that results in a significantly reduced ejection fraction, again typically 35%, is a strong indication for an ICD for secondary prevention. ICDs are also implanted for certain genetic heart conditions that carry a high risk of sudden death, like hypertrophic cardiomyopathy if certain risk factors are present, long QT syndrome, arrhythmogenic right ventricular dysplasia, ARVD, and Brugada syndrome, especially if the patient has had syncope, fainting, or documented VP.
They're also used as a bridge for patients awaiting a heart transplant, and in specific inflammatory conditions of the heart known to cause dangerous arrhythmias, like cardiac sarcoidosis or giant cell myocarditis.
And I assume ICDs also have their own set of codes, similar to the ASURE codes for pacemakers, but tailored to their specific shock and anti-tachycardia functions.
Yes, they do. It's a similar concept, providing a shorthand for the device's capabilities. The first letter in the ICD code typically describes the chamber that will receive the shock, O none, A, atrium, V ventricle, D dual. The second letter indicates the chamber where anti-tachycardia pacing, ATP, occurs, again, O, A, V, or D. The third letter denotes the device's method of tachycardia detection, how it decides if a fast rhythm is dangerous. E, electrocardiogram-based, H, hemodynamic sensor-based, O, none. And the fourth letter identifies which chamber will provide backup antibradycardia pacing if that feature is enabled, O, A, V, or D. And it's really crucial to remember, as you said, that the ICD's pacemaker function, the part that handles the slow rhythms, follows the exact same standard HRS pacing coding system like VVI, DDD, etc., that we discussed earlier for pacemakers. It's embedded within the ICD's overall function.
Okay, now this next point feels absolutely critical, and it's something I know can cause confusion, even among experienced professionals. How do ICDs respond to magnets? Is it the same deal as a pacemaker, where a magnet triggers asynchronous pacing?
This is a very, very important distinction, and it's absolutely vital for any clinician, especially one aiming for mastery, to understand this correctly to avoid potentially dangerous errors. ICDs can be programmed and usually are to recognize a magnet. When a magnet is placed correctly over the device, its primary effect is to temporarily disable or suspend shock therapy. However, and this is the key warning that cannot be overstated, not all devices are programmed to respond this way, although most modern ones are. You must confirm this preoperatively. And here is the absolutely crucial difference from pacemakers that must be ingrained in your thinking. A magnet placed on an ICD will not initiate asynchronous pacing. It does not affect the bradycardia pacing mode in most devices. This point has historically caused significant confusion and can lead to truly hazardous situations if it's not clearly understood and remembered. Any healthcare provider managing these patients must be intimately familiar with the device codes, the specific terminology, and the capabilities, including the exact magnet response to properly manage and, if necessary, manipulate the ICD during the perioperative period. Assuming a pacemaker response is a recipe for trouble.
Wow. Okay, so if a magnet won't trigger asynchronous pacing in an ICD, how does the ICD decide when to actually deliver therapy? What's its internal strategy when it detects one of those dangerous fast rhythms?
Modern ICDs employ incredibly sophisticated and complex algorithms. These are programmed into the generator by the electrophysiologist to activate the tachyarrhythmia detection and therapy features only when a truly malignant rhythm occurs. These algorithms are designed to meticulously analyze the heart's rhythm. They sense the R-to-R intervals, evaluate the rate, assess how abruptly the fast rhythm started, and determine if the rhythm is sustained over time. It's an intricate dance of analysis, constantly weighing evidence to ensure accuracy and avoid inappropriate therapy.
So it's analyzing multiple features of the rhythm, not just a simple heart rate number. If it does detect a fast, dangerous rhythm, what's its first line of defense? Does it always go straight to a shock?
Not necessarily. Often its first line of defense is something called anti-tachycardia pacing, or ATP. If the rhythm meets criteria for ATP, the device will initiate short, rapid bursts of pacing pulses delivered at a rate that's actually faster than the intrinsic tachycardic rate. The goal here is to electrically capture the heart muscle briefly, and then by stopping the pacing, allow the heart's natural pacemaker to regain control, effectively overdriving and disrupting the abnormal circuit, terminating the rhythm without needing a painful shock. It's often very effective for organized VTs. If ATP isn't effective, or if the rhythm is immediately recognized as something chaotic and life-threatening like ventricular fibrillation, VF, then the ICD will proceed to deliver a shock. It typically uses lower energy levels, maybe 1 to 30 joules, to cardiovert ventricular tachycardia, VT, and higher energy levels, perhaps 10 to 30 joules or more, to defibrillate ventricular fibrillation, VF. Importantly, if the ICD determines that the rhythm truly requires defibrillation for VF, it's typically programmed to deliver a sequence of shocks, often up to 6, with escalating energy if needed. And once a shock is delivered, the ICD might temporarily disable further anti-tachycardia pacing attempts for that episode, allowing the heart rhythm to be reassessed before deciding on the next therapy.
The evolution of these devices from those, bulky units needing major surgery and abdominal placement to what we have today, it sounds truly incredible. What's next? What's on the horizon? Are they getting even smaller, maybe even leadless, like those pacemakers you mentioned? And what are the implications?
Absolutely. The progress has been stunning. Over the last decade, there has been just tremendous forward momentum in the design and engineering of both pacemakers and ICDs, largely driven by advances in battery technology and miniaturization. You mentioned leadless pacemakers. That's a prime example. Advances led to the development of the leadless single-chamber intracardiac pacemaker. This is a major game changer in the field.
A leadless pacemaker. That really does sound like something out of science fiction almost.
It feels like it, but it's very real and increasingly used. These leadless pacemakers are tiny, approximately 1/10 the size of a traditional single-chamber pacemaker. Think of a large vitamin capsule. They are implanted directly inside the right ventricle via catheter inserted in the femoral vein in the leg. This means no chest incision, no subcutaneous pocket for the generator, and, crucially, no leads running through the veins or detached to the heart surface. Despite their minuscule size, these devices are engineered with sophisticated functionality and features that essentially match their larger traditional predecessors for single-chamber pacing. The benefits are potentially huge, eliminating many complications associated with traditional pacemaker implantation, like infection of the pocket, lead fracture or dislodgement, or hematoma formation. This could lead to fewer hospitalizations and ultimately lower healthcare costs. Another interesting advantage is that these current intracardiac devices don't require surgical removal at the end of their battery life. They're engineered to simply convert to a non-functional U mode, essentially going dormant when the battery voltage reaches its end of service.
That's fascinating. What about on the ICD side? Are there leadless options there or similar advancements?
Yes, there's a significant advancement there too, although slightly different. It's the subcutaneous ICD, often called the SICD. This device received FDA approval back in 2013. It's specifically indicated for terminating life-threatening ventricular tachycardias in certain patient groups, maybe those with structural or congenital heart disease, those who have problems with venous access, making traditional leads difficult, or individuals at particularly high risk of device-related infection. With the SICD, the pulse generator is implanted subcutaneously under the skin, usually along the left lateral chest wall, near the armpit. The lead, which contains the shock coil, is also positioned subcutaneously, tunneled along the left side of the sternum. Nothing goes inside the heart or blood vessels.
Okay, so it's entirely under the skin without any components actually entering the heart or veins. That's a fundamentally different approach from a traditional ICD.
That's exactly right. It's a major difference. Unlike traditional ICDs, with those intracardiac leads delivering energy from inside the heart, the SICD delivers higher energy defibrillation shocks from outside the heart, across the chest wall. However, it does have important limitations that any professional needs to be acutely aware of. Firstly, it's not indicated for patients who require pacing for bradyarrhythmias, slow heart rhythms, because the device will deliver only a very brief period, maybe 30 seconds, of immediate post-shock pacing for bradycardia. It cannot provide continuous pacing support. And secondly, and this is critical for perioperative management, this particular subcutaneous device is not sensitive to manipulation with a magnet. Placing a magnet over an SICD will do absolutely nothing. That's another crucial distinction to remember.
Wow, okay, that's a huge amount of incredible, constantly evolving technology. But now let's really get into the heart of why this deep dive is so critical for actual patient safety, navigating that perioperative minefield. When a patient has a CID and is undergoing surgery, this is where all this detailed knowledge, this mastery truly comes into play, isn't it?
This is absolutely where knowledge translates directly and critically into patient safety. For any patient scheduled for any kind of surgical procedure, that preoperative phase is just vital. They obviously need to be medically optimized, undergo a thorough history and physical exam, get any indicated lab tests done, and have a comprehensive assessment of all their comorbidities. Standard stuff. However, the surgical patient who also has a CID requires truly special focused attention. Their device introduces a unique and potentially hazardous layer of complexity that has to be proactively managed.
This really sounds like it demands a collaborative team effort. Who absolutely needs to be involved in planning the care for a patient with a CID coming for surgery?
Precisely. A multidisciplinary team approach isn't just, a good idea, it's essential. And it needs to be highly collaborative with clear communication. This team typically involves the patient's cardiologist, or ideally their electrophysiologist, the heart rhythm specialist, the anesthetist who will be managing the patient during the procedure, the device programmer who is often a specialized technician from the CIE manufacturer, and, of course, the surgeon performing the operation. They all need to sit down, figuratively or literally, and consider several critical factors together. The specific type of CIE the patient has, the exact location of the pulse generator, is it near the surgical field, the type and anticipated length of the surgical procedure, the expected use of electrosurgical cautery, especially monopolar, and even the patient's planned surgical position. Will it affect access to the device? Additionally, it's absolutely essential to know beforehand how to access a device-specific programmer if needed urgently, and to have the manufacturer's technical support contact number readily available. Companies like Biotronic, Boston Scientific, Medtronic, St. Jude Abbott, they all have dedicated support lines for these situations, and they can be invaluable in a pinch.
Beyond just knowing who to call, what are the essential sources of information about the patient's specific CIED that any professional involved needs to gather diligently beforehand?
One immediate, though often incomplete, starting point is the manufacturer-generated wallet card that the patient usually carries. This card typically lists the type of device, pacemaker or ICD, the model and serial number, the date it was implanted, the name of the implanting physician or clinic, and contact info for the manufacturer. However, and this is crucial to understand its limitations, the card doesn't usually include the date when the CIED was last checked or interrogated. Nor will it confirm if the CIE has actually been functioning properly recently or if any issues or alerts have been flagged by the device. It's a foundational piece of information, but it's far from the whole story.
Okay, so the wallet card is a start, but definitely not the full picture. What's the more comprehensive and frankly the vital way to get that up-to-date, actionable information?
That would absolutely be through routine device interrogation. This means having a trained professional use the specific manufacturer's programmer to communicate directly with the device. The Heart Rhythm Society generally recommends this assessment yearly for pacemakers and every 6 months for ICDs, or more frequently if needed clinically. A thorough device interrogation provides a wealth of critical, real-time data that you just can't get otherwise. It tells you the date of the last interrogation, the exact type of device, its manufacturer and model number, the specific reasons, indications for its placement, its current estimated battery life, crucial, the integrity of the leads, are they functioning correctly, the pacemaker's program settings and the patient's underlying native heart rhythm, any ICD therapy like shocks or ATP that has been delivered recently, its specific programmed response to magnet application, and any diagnostic alerts the device may have generated about potential problems.
That's a ton of detail. Why is getting all of that information so important, especially knowing about any recent therapy delivered by an ICD?
Knowing about any recently delivered anti-tachycardia therapy, for example, is a huge piece of the puzzle when planning perioperative management. If an ICD has recently shocked the patient multiple times for VT or VF, that information might directly influence the decision about whether temporarily disabling shock therapy during surgery is actually a safe plan for that specific patient, or if it would leave them unacceptably vulnerable. For professionals striving for elite practice, performing an incomplete preoperative assessment or simply failing to thoroughly investigate a CIE's status and programmability is just not acceptable. It can, and sometimes does, lead directly to poor, even catastrophic patient outcomes. This level of detailed assessment isn't just bureaucratic box ticking, it's absolutely central to providing precise, safe patient care.
What happens if it's an emergency situation? A trauma case comes in, needs immediate surgery, and there simply isn't enough time for a full formal interrogation of the device before rushing to the OR? Are there quick, essential ways to gather some critical information about the CIE rapidly?
That's a tough but realistic scenario. In an emergency, when time is absolutely critical and a full interrogation isn't feasible, assessing the ECG and getting a quick chest X-ray can be invaluable first steps, offering immediate clues. A 12-lead ECG might reveal a paced rhythm, but remember, only if the heart is actually being paced at that exact moment. It won't tell the provider about the underlying native rhythm, whether the patient is pacemaker dependent, the specific type of device, or, crucially, how it's programmed to respond to a magnet. It merely provides a real-time snapshot of the heart's electrical activity. It's useful, but limited.
Okay, so an ECG alone isn't enough in that emergency scenario. What about a chest X-ray? What can that tell us quickly?
The patient's chest X-ray is another potentially vital, rapidly obtainable source of information. Every CIE generator has a unique manufacturer identifier visible on X-ray. It might be a specific shape, a logo, or a radiographic code embedded in the can. With the right resources, like online databases or apps, this identifier can sometimes be used to quickly determine the manufacturer and possibly even the specific model family of the device. That's huge. The chest X-ray can also visually alert the provider to the type of device. Is it likely a pacemaker, suggested by the presence of thinner lead wires only? Or is it likely a defibrillator or combo device, strongly suggested by the presence of one or two thicker, more radiopaque lead shot coils? Or maybe it's one of those leadless capsules. This gives you a quick visual classification: pacemaker versus ICD versus SICD versus leadless.
And what about trying a magnet in an emergency? Can that give us quick information, or is that exactly where that generalizations or dangerous rule really kicks in hard?
You're hitting on a very critical point of caution here. Additional information might, emphasis on might, be obtained by placing a magnet correctly over a CIED in an emergency. If the device happens to be a pacemaker-only device and is programmed for a standard magnet response, you might see asynchronous pacing immediately appear on the ECG monitor, a fixed pacing rate. If the device is an ICD, there might be an audible tone emitted from the device, depending on the manufacturer and programming, indicating that antitachycardia therapy has been suspended. However, and this cannot be stressed enough, it is critically important to remember that not all CIEDs respond in these predictable ways. For instance, as we mentioned at the time of this recording, ICDs made by Boston Scientific and Medtronic often elicit that audible tone with magnet placement, confirming shock suspension. But ICDs in St. Jude Abbott, Biotronic, and Sorin generally do not emit a tone, even if the magnet is successfully suspending therapy. This significant manufacturer variation, along with potential for non-standard programming, absolutely underscores the need for specific device knowledge and highlights why just slapping on a magnet blindly in an emergency without knowing the expected response is inherently risky and not best practice if avoidable.
Okay, so beyond the external interference from surgical tools, what about internal factors within the patient themselves? Can the patient's own body chemistry or physiology affect how a CIED functions? It sounds like it's not just about outside signals.
You're absolutely right. The patient's internal environment, their own physiology, plays a huge role and can definitely affect CIE function. Several internal patient factors can adversely impact how well a device works, often by altering the myocardial threshold, that minimum electrical jolt needed for the heart muscle to actually respond to a pacing stimulus. For instance, shivering can sometimes inhibit pacing because the device's sensing circuit picks up the muscle tremors as if they were cardiac contractions. It gets fooled. Similarly, fasciculations, those fine muscle twitches you might see after giving a drug like succinylcholine, can also inhibit pacing for the same reason they look like cardiac signals to the device. Electrolyte changes, particularly significant shifts in potassium or calcium levels, can directly affect the pacing threshold, making capture more difficult. The same goes for temperature fluctuations, especially hypothermia, and significant pH imbalances, acidosis or alkalosis. They all can alter that myopotential threshold. Hypothermia specifically also increases the arrhythmogenicity of the heart muscle itself, making dangerous rhythms more likely. Even things like blood transfusions can indirectly affect capture by altering the patient's pH, temperature, or electrolyte balance. And interestingly, certain chemotherapy drugs have been documented to sometimes cause a loss of pacemaker capture because they seem to elevate that capture threshold over time.
It really is like having a very sensitive microphone that can sometimes pick up unintended background noise or have its function altered by the room's acoustics, leading it to react incorrectly.
So it's definitely not just about the external signals from equipment. The patient's own internal state is a huge factor. But speaking of those external signals, you flagged EMI earlier as the biggest threat in the operating room. Let's dig deeper into that. What exactly is it again, and how does it actually manifest in the OR?
Right, EMI. Electromagnetic interference. As we defined it, it's basically any external electrical signal that's not generated by the heart itself, non-physiologic, that interferes with the normal function of a pacemaker, or an ICD. These EMI sources are present both inside and outside the hospital environment, but the intraoperative period significantly, dramatically increases the patient's exposure to potential EMI sources, especially strong ones. Now, the degree to which EMI might interfere with the CIED is highly variable. It depends on the type and strength of the EMI source, how close it is to the device, how long the exposure lasts, and the specific design and programming of the CIED itself. Possible general responses of the device when it encounters significant EMI can include inhibition of pacemaker function, oversensing, inappropriate triggering of pacing, a complete electrical reset of the device back to factory default settings, actual physical damage at the interface between the lead tip and the heart tissue due to induced currents, and the device simply tracking the electrical noise as if it were a legitimate fast heart rhythm.
Given all this potential risk, have modern CIEDs evolved to handle this better? Are they built with EMI protection in mind?
Yes, absolutely. The manufacturers are very aware of this issue. Modern CIEDs have been engineered with increasingly sophisticated internal filtering capabilities, specifically designed to try and screen out non-cardiac electrical signals. This is a constant area of R&D. The goal is to minimize the potential clinical consequences of encountering EMI in daily life and in the hospital. However, and this is the crucial caveat, despite these significant technological advancements in filtering and shielding, the potential for strong EMI to still alter CIE function definitely persists. It's not foolproof. This reality necessitates a consistently vigilant and informed approach whenever managing patients with an implantable device, particularly in environments like the OR or electrophysiology lab, where strong EMI sources are common. You just can't assume the filtering will prevent all problems.
And what is the single most common, most prevalent source of EMI that healthcare professionals absolutely need to be acutely aware of, especially in the operating room?
Without a doubt, the most prevalent and often most problematic source of EMI in the operating room is electrosurgical cautery, often just called EC, or more colloquially, the boovie. This tool is indispensable in nearly all surgeries. It's used constantly to stop bleeding by either cutting tissue with high-frequency current or coagulating blood vessels. And there are two main types frequently employed that behave quite differently regarding EMI, monopolar and bipolar cautery.
Okay, let's start with monopolar cautery, the one people often just call the boovie. How does that specific type affect CIEDs? Why is it generally considered riskier?
Monopolar cautery is generally riskier because it produces significantly more electrical energy than bipolar cautery. And, critically, it requires the placement of a separate grounding pad somewhere else on the patient's body to complete the electrical circuit. The current flows from the active electrode tip through the patient's body to this grounding pad. Now, the distance between that electrocautery tip, where the surgeon's working, and the grounding pad determines the entire area or pathway through the patient's body where stray electrical current can flow. And it's this stray current that can be easily sensed by a nearby CIE and potentially misinterpreted as cardiac activity. The principle is strikingly similar to how a unipolar pacing lead creates a larger sensing antenna. The current path is wide. For this reason, the grounding pad for monopolar cautery should always be positioned strategically. It should be placed near the actual surgical site, but as far away from the CID generator and leads as practically possible. The goal is to minimize the chance of the current pathway passing right through or near the device.
And bipolar cautery, how is that different, and is it generally considered safer for patients with CIEDs?
Bipolar electrocautery devices work on a fundamentally different principle. They have both the active and return electrodes located very close together, right at the tip of the instrument. It looks like tweezers. The electrical current flows only between these two closely spaced tips. Because of this highly localized current path, there's significantly less opportunity for stray interference to spread and be misread by the CIE. The circuit is much smaller and contained. Consequently, a grounding pad is not necessary with bipolar cautery, and it generally exerts less overall electrical energy. All these factors make bipolar cautery generally much safer for use in patients with CIEDs whenever it's surgically appropriate. However, a crucial point for any professional in the OR to remember. If for some reason it becomes necessary to switch from using a bipolar device to a monopolar device during the procedure, a grounding pad must be immediately placed on the patient before the monopolar cautery is activated. Forgetting that step can be dangerous. It's also common practice, although large controlled studies proving definitive efficacy are somewhat lacking, for surgeons and anesthetists to recommend using short bursts of cautery energy, typically less than 5 seconds at a time, or using the lowest effective energy settings possible. These techniques are frequently employed as practical strategies to try and reduce the incidence of device interference, especially with monopolar cautery.
Okay, so monopolar is generally riskier due to that wider current path needing the grounding pad. How exactly does EMI, particularly from cautery, affect pacemakers specifically? What are the concrete dangers we need to understand?
When a pacemaker encounters significant EMI, its sensing circuit can misinterpret that electrical noise as if it were legitimate cardiac electrical activity, sometimes even thinking it's a serious cardiac dysrhythmia. If the pacemaker is programmed in a mode that allows it to be inhibited, like DDD or VVI, it may interpret the EMI as intrinsic heartbeats and consequently inhibit its pacing output. This phenomenon is called oversensing. This is probably the most common and potentially the most dangerous effect of EMI on a pacemaker. Why? Because if the patient is pacemaker dependent, meaning their own heart doesn't generate a reliable beat on its own, this inhibition results in a sudden, complete loss of mechanical cardiac activity. That's an immediate life-threatening emergency, a systole or severe bradycardia, if no underlying escape rhythm emerges very quickly.
That sounds incredibly dangerous, just stopping the heart effectively. Are there other negative effects EMI can have on a pacemaker beyond just inhibition?
Oh, absolutely. The potential negative effects are quite varied. Ironically, sometimes the EMI might be viewed simply as noise by the pacemaker, which, depending on the device and programming, could actually trigger asynchronous pacing, like switching to VOO or DOO mode. If this asynchronous pacing happens at an inopportune moment relative to the heart's own rhythm, it could potentially cause an R-on-T phenomenon. That's where a pacing spike lands on the vulnerable T wave of the preceding beat, which can, in rare cases, trigger a lethal arrhythmia, like ventricular fibrillation. Strong EMI can also theoretically be conducted down the lead wire itself, potentially causing enough current at the tip to damage the heart muscle via an endocardial burn, though this is rare with modern devices. It can certainly decrease the pacemaker's battery life faster than expected due to increased current drain or processing demands. In some documented cases, severe EMI has caused the device to perform an electrical reset back to its factory default settings, which might not be appropriate for the patient, or switch to an unexpected alternate backup pacing rate. It might even be misinterpreted specifically as P waves, causing a dual-chamber device to pace only the ventricle in response, leading to a loss of that important intro kick, which normally contributes significantly to cardiac output. In the most severe scenarios, as mentioned, EMI can result in profound bradycardia or even a systole if inhibition occurs in the dependent patient. And there's always the potential, though less common now, for EMI to actually reprogram or permanently alter the device's settings, or to alter the electrical thresholds required for capture, potentially eliminating proper capture altogether even after the EMI stops. The list of potential problems is quite extensive, which is why vigilance and proactive management are absolutely paramount.
That's a sobering list of potential problems just for a pacemaker. How do the effects of EMI differ when we're talking about ICDs, the devices designed to deliver those powerful shocks? Are the risks the same or different?
The effect of EMI on an ICD is distinctly different from its effect on a pacemaker, and in some ways, potentially even more immediately alarming for the patient and the clinical team. When significant EMI is present, the ICD generator's sophisticated sensing algorithms may misinterpret that electrical signal as a potential malignant tachyarrhythmia, specifically ventricular tachycardia, VT, or ventricular fibrillation, VF. If this interference, perhaps from prolonged continuous use of monopolar cautery near the device, lasts long enough for the ICD's detection algorithm to classify it as VT or VF, the device will then proceed to charge its capacitor and deliver an anti-tachycardia therapy, either ATP or, more likely in this scenario, an unnecessary, unwarranted high-voltage shock.
Oof, that sounds terrifying for an awake or lightly sedated patient receiving an unwarranted shock. Is there a way for clinicians in the OR to quickly tell if the chaos on the ECG is just EMI noise or if it's a true dangerous arrhythmia requiring that shock?
Fortunately, yes, in most cases, there's a critical way to differentiate during surgery. ECG interference noise can often be distinguished from true VT or VF by simultaneously looking at the patient's hemodynamic monitoring, specifically the pulse oximeter waveform, or
even better if available, the invasive arterial pressure waveform. Both the pulse oximeter plethysmograph and the arterial waveforms displayed on the monitor will typically remain intact and show a regular pulse contour consistent with the patient's actual heart rate. If the electrical noise on the ECG is just EMI and not a true malignant rhythm causing loss of cardiac output. If the pulse waveform suddenly disappears or becomes chaotic, then you're likely dealing with a true life-threatening arrhythmia. However, despite the sophistication of modern detection algorithms, it's important to note that the device itself might still misinterpret strong EMI and make an incorrect determination, initiating an unwarranted shock even with an intact pulse. These algorithms aren't perfect. This risk of inappropriate shocks is precisely why knowing the device's specific programming and characteristics before the procedure is so crucial. It directly informs the anesthesia practitioner's decision on whether preoperative reprogramming to disable tachycardia therapies is warranted, or if temporary magnet placement during EMI exposure is a reasonable alternative strategy for that specific patient and procedure.
What are the other potential negative effects that EMI can have on an ICD, besides just triggering an unnecessary shock?
Besides inappropriate shocks, EMI can, paradoxically, have the opposite and equally dangerous effect. It can critically inhibit antitachycardia therapy. The noise might confuse the device so much that it fails to recognize a real episode of VT or VF, preventing it from delivering a life-saving shock when truly needed. Just like with pacemakers, strong EMI could potentially be conducted down the ICD lead, causing myocardial damage via an endocardial burn at the lead tip, although again, this is less common with modern systems. There have been cases where severe EMI has caused an ICD to permanently deactivate or enter a default magnet mode state, rendering it unable to detect or treat lethal rhythms altogether until reprogrammed in an incredibly dangerous situation. Furthermore, EMI can potentially corrupt programming and alter detection thresholds of therapy settings, or it might even affect the rate adaptive pacing function if present, causing the device to inappropriately increase the heart rate in response to non-physiologic noise, leading to unnecessary myocardial oxygen demand during surgery.
Okay, so while electrosurgical cautery is clearly the main culprit we worry about in the OR, what other sources of EMI within the hospital environment can interfere with CIEDs? It's not just a problem confined to the surgical suite, is it?
You're absolutely right. EMI isn't just an OR problem. It's a potential concern throughout the hospital environment, and clinicians in various departments need to be aware. Other potential sources within the hospital that can generate significant EMI and potentially disrupt CIE function or programmability include things like transcutaneous electrical nerve stimulators, TNS units, often used by physical therapy or pain management services. Also, spinal cord stimulators, which are becoming more common for chronic pain. Extracorporeal shockwave lithotripsy, ESWL, used in urology to break up kidney stones, generates powerful shockwaves that can sometimes affect devices. Radiation therapy delivered in oncology departments for cancer treatment poses a significant risk. Electroconvulsive therapy, ECT, used in psychiatry for severe depression, involves passing electrical current through the brain. Radiofrequency ablation, RFA procedures, often used in cardiology or interventional radiology to treat arrhythmias or tumors, use high-frequency energy. And critically, as we discussed briefly, magnetic resonance imaging, MRI, used ubiquitously in radiology, involves extremely powerful magnetic fields and radiofrequency pulses. Any professional managing patients with CIEDs must be aware of the potential risks associated with these varied procedures and environments, and know the appropriate options for minimizing interference and managing the consequences if CIE malfunction occurs.
Let's quickly touch on some of the specific recommendations for managing CIEDs when patients undergo these non-operative procedures or diagnostic tests, pulling from that expert-level guidance.
Okay. For electrosurgery, monopolar being used outside the main OR, say in an endoscopy suite or clinic, if it's planned for a procedure superior to the umbilicus above the belly button, it's generally essential to temporarily alter the pacing function to an asynchronous mode, like VOO or DOO, to prevent inhibition from oversensing. And always position the active electrosurgical instrument and the dispersive grounding electrode so that the electrical current pathway intentionally avoids the CIE generator or lead as much as possible. For extracorporeal shockwave lithotripsy, ESWL, the primary precaution is to avoid focusing the shockwave beam directly near the CIE generator. While current lithotriptors are generally considered lower risk than older models, there have still been documented cases of inappropriate sensing and pacing inhibition during ESWL, so vigilance is still needed.
And for those treatments that involve delivering electrical currents directly or using very strong magnetic fields like ECT or MRI.
Right. With electroconvulsive therapy, ECT, where electrical current is administered to the brain, the typical initial cardiovascular response is often a brief period of bradycardia or even a systole due to vagal stimulation, followed immediately by a significant tachycardia and hypertension surge. This subsequent tachycardia can easily be misinterpreted by an ICD and result in inappropriate shocks. Therefore, for pacing-dependent patients undergoing ECT, it's crucial to alter the pacing function to an asynchronous mode beforehand. And for patients with ICDs, it's standard practice to temporarily suspend or disable all ICD antitachycardia functions, both ATP and shocks, before ECT, as that post-seizure tachycardia is expected and should not be treated by the device. If the CIE is known to be programmed to respond appropriately to a magnet, temporary magnet application during the ECT procedure itself is often considered a reasonable management option to suspend shocks. For radiofrequency ablation, RFA procedures, especially those performed above the umbilicus, it's often necessary to completely deactivate the CIE temporarily during the ablation portion. Also, a general precaution is to avoid using handheld radiofrequency identification, RFID devices, in very close proximity to a patient's CIED, as there's a theoretical risk of interference.
MRI is always the big one people ask about, given those incredibly powerful magnetic fields. How does that interaction really work, and what are the specific risks involved?
MRI is indeed a significant concern because of its combination of a very strong static magnetic field, gradient magnetic fields that change rapidly, and powerful radiofrequency pulses. All of these can potentially interact with the CIE. As you know, medical devices are now categorized by the ASTM into 3 groups regarding MRI safety. MIS-R safe, no metal, no known hazards. MIS-R conditional, safe only under very specific defined conditions of use. And MIS-R unsafe, known hazards prohibited in all MIS-R environments. Most CIEDs fall into the unsafe or conditional categories. MRI examinations can definitely interfere with CIED function in several potentially dangerous ways. Possible adverse events specific to MRI include the static magnetic field closing the reed switch, forcing subsequent asynchronous pacing, which might be okay or might compete dangerously with the native rhythm. The radiofrequency pulses can induce currents in the leads, potentially causing thermal injury, burns at the electrode-myocardial tissue interface. And the rapidly switching gradient fields can sometimes induce voltages that lead to unintended rapid pacing or inhibition. All of these are serious potential risks.
So what's the detailed step-by-step management strategy for getting an MRI scan for a patient with a CIED, especially for those older devices not specifically designed or approved as MR conditional?
Okay, managing MRI in CIED patients requires a very strict protocol, especially for non-conditional legacy devices. Some manufacturers have developed FDA-approved MinR conditional CIED systems. Both the generator and specific leads must be part of the approved system. Even these still require careful reprogramming into a specific MRI mode prior to the scan, often involving disabling therapies and potentially forcing asynchronous pacing. Manufacturers also typically require facilities performing scans on these conditional devices to undergo special training and adhere to strict protocols regarding scanner field strength, positioning, and monitoring. Continuous monitoring of these MR conditional leads post-scan is also often recommended due to theoretical risks. Now, for non-conditional devices, the management is far more stringent, and often MRI is considered contraindicated unless the diagnostic benefit clearly outweighs the risks, and alternatives are unavailable. If an MRI must be done, the patient should be moved outside the immediate strong magnetic field area, Zone 4, if any external equipment like a defibrillator monitor, the CID programmer itself, or any other MinR unsafe equipment is needed. The CIED must be thoroughly interrogated immediately before the scan. For ICDs, all anti-tachycardia functions must be suspended before entering the scanner room. For pacing-dependent patients, the CIED pacing function must be altered to an asynchronous mode before the scan. Critically, an individual fully capable of programming the specific device, usually an electrophysiologist or manufacturer rep, must remain physically present and immediately available for the entire duration of the MRI scan. And, without fail, the CIE must be fully reinterrogated and reprogrammed back to its baseline settings immediately after the scan is completed, before the patient leaves the MRI suite, to ensure it's functioning correctly and therapies are restored. It's a complex, high-risk, multi-step process requiring truly expert oversight.
And what about radiation therapy? That also involves powerful energy delivery. What are the risks and precautions there?
With radiation therapy, the primary concern is that the ionizing radiation can directly damage the sensitive electronic components, the circuitry, the memory, within the CIED generator, potentially causing unpredictable malfunction or even permanent failure. Therefore, the main goal is to avoid exposing the CID generator to the direct radiation beam whenever possible. Strategies include carefully planning the radiation fields to exclude the device, using lead shielding over the CIE if feasible, or sometimes even surgically relocating the generator to the patient's opposite contralateral side if it lies directly within an unavoidable high-dose radiation field. It's also very important to check the specific manufacturer's recommendations, as they often advise functional verification of the CIE before starting a course of radiation, periodically during the course, especially for high doses near the device, and again after the full course is completed. Therapeutic levels of radiation carry significantly increased risk of causing CI dysfunction and permanent changes. While diagnostic levels of radiation, like from X-rays or CT scans, usually don't have a clinically significant impact, there have been rare documented cases of oversensing or even electrical reset occurring during CT scanning, so awareness is still needed.
What if a patient with a CIED needs urgent external cardioversion or defibrillation, say in the ER or ICU? How does that interact with the implanted device?
In those urgent life-saving situations, the immediate priority is treating the patient's lethal arrhythmia. However, there are important considerations regarding the CIE. Firstly, the external defibrillation paddles or pads should never be placed directly over the CIE generator itself. Doing so could potentially damage the device with a high current. Instead, they should ideally be positioned in an anterior-posterior configuration, one on the front, one on the back, or at least an anterolateral position that avoids placing a pad directly on top of the implanted device. Secondly, the lowest possible effective energy setting required to successfully achieve cardioversion or defibrillation should be used. This is because transient increases in the heart's pacing threshold, making it harder for the pacemaker to capture, have been documented following external cardioversion shocks. Using excessive energy unnecessarily might exacerbate this effect. And, as always after such an event, interrogation of the CIE is strongly advised as soon as feasible following any external cardioversion or defibrillation, just to ensure its integrity and continued proper function, and to check if thresholds have changed.
Are there any other notable sources of EMI or interference, maybe less common ones, that professionals should keep in the back of their minds?
Yes, a couple more worth mentioning briefly. Transcutaneous electrical nerve stimulators, TKNS, those small devices used for pain relief, generate electrical pulses that can sometimes be misinterpreted by pacemakers. Their use in patients with pacemakers should generally be approached cautiously, ideally only after extensive safety testing in that specific patient, when there's a clear demonstration of exceptional improvement in quality of life, and then probably only used intermittently with careful monitoring. Similarly, for implanted spinal cord stimulators, SCS, used for chronic pain, individual testing should ideally be performed before initiating permanent SCS therapy in a patient with a CIED. This is to ensure that the SCS pulses don't cause unintended pacemaker inhibition, or, in the case of an ICD, inappropriate triggering of antitachycardia therapy. The key theme across all these varied potential sources is the need for vigilance, individualized assessment, and understanding the potential for interaction.
Okay, so with all these potential interferences swirling around, especially during surgery, what's the proactive plan? How do clinicians operating at that elite professional level actively mitigate these risks? What are the main strategies?
Right. The potential for encountering significant intraoperative EMI absolutely necessitates having a clear, appropriate, and pre-discussed plan to mitigate its potentially harmful effects on the CIE. Often the most reliable and controllable strategy is reprogramming the device into a safer mode for the duration of the surgery or procedure. Reprogramming is strongly recommended, almost mandatory, whenever there is a high expectation of encountering significant EMI. This is particularly true when monopolar cautery is planned to be used, especially if the surgical site is in close proximity to the CIE generator or leads, for example, chest or upper abdominal surgery. While the influence of EMI cannot be entirely eliminated from the operating room environment, the device's response to that environment can certainly be manipulated and controlled through reprogramming to identify and manage its impact safely.
And reprogramming allows for those very specific temporary changes to how the device behaves, correct?
Precisely. Using the device-specific programmer, a trained professional again, often a company rep or an electrophysiologist, can temporarily modify the device's settings just for the duration of the procedure. For a pacemaker, this typically involves programming it into an asynchronous mode, like VOO, AOO, or DOO. This forces it to pace at a constant rate regardless of any sensed EMI, thereby preventing potentially dangerous inhibition caused by oversensing. For an ICD, the most common reprogramming step is to temporarily disable all antitachycardia therapies, both ATP and shocks. This prevents the delivery of inappropriate, unwarranted shocks that could be triggered by misinterpretation of EMI noise as VT or VF. This temporary controlled modification of the device's function is absolutely critical for ensuring patient safety during procedures with high EMI risk.
You mentioned rate modulation earlier, that feature where the pacemaker adjusts the heart rate based on physical activity. Should that generally be disabled during surgery as well?
Yes, disabling rate modulation intraoperatively is generally strongly recommended as part of the reprogramming plan. The rate modulation mode, while beneficial for active patients outside the OR, is not intended to increase the heart rate indiscriminately based on non-physiologic signals. However, during surgery, various stimuli present in the OR, things like patient shivering, hyperventilation, coughing, or bucking against the ventilator during anesthesia emergence, or even just the mechanical vibrations from surgical tools or the ventilator itself, can sometimes be misinterpreted by the pacemaker's rate adaptive sensors, which might be motion sensors or minute ventilation sensors. This misinterpretation can result in inappropriate and potentially hemodynamically detrimental increases in the pacing rate when it's not actually needed. Disabling rate modulation temporarily prevents this unwanted, potentially EMI-induced response, ensuring a more controlled and predictable heart rate during the anesthetic.
Okay, so beyond sophisticated reprogramming using the specific programmer, you've also alluded several times to using magnets as another potential strategy in the OR. What's the proper role of magnet application in mitigating these EMI risks? Is it like a universal backup plan?
The placement of a standard clinical magnet, usually a 3-inch round, horseshoe, or rectangular one directly over the CIED generator, is indeed another commonly discussed strategy to try and offset the effects of intraoperative EMI. However, it is definitely not a universal solution or a simple backup plan that works the same way for all devices. It's much more nuanced than that. Critically, before relying on a magnet intraoperatively, a thorough preoperative interrogation of the device using the programmer is essential. This interrogation will confirm if the specific CIED is programmed to be magnet sensitive, and crucially, exactly how it is programmed to respond when a magnet is applied, assuming a standard response is risky.
Let's clarify that response again. How do pacemakers, specifically the PM-only devices, typically respond to magnet application, assuming they're programmed for it?
Right. For most modern pacemakers, PM-only devices, they are typically programmed to acknowledge the presence of a magnet. The primary effect is that the pacemaker converts from whatever synchronous mode it was in, like DDD or VVI, to an asynchronous pacing mode, like DOO or VOO, at a specific predetermined magnet rate. This magnet rate is often set to be slightly more rapid than the patient's typical intrinsic heart rate, frequently somewhere between 85 and 100 beats per minute. The rationale for this faster rate is partly historical, but also aims to decrease the potential for competitive pacing or inducing RNT phenomena if the patient has an underlying rhythm. As an additional effect, magnet application will also temporarily suspend the rate modulation feature on some, but not all, pacemaker devices.
But there's that crucial catch again, isn't there? Not all pacemakers respond identically, meaning assumptions based on most devices are dangerous for that elite professional mindset.
It's exactly right. This is where generalizations can lead you astray, and why aiming for mastery requires knowing the specifics. Each pacemaker model can be programmed differently by the cardiologist or electrophysiologist. The magnet response might be programmed differently, or it might even be deliberately disabled entirely for specific clinical reasons. Furthermore, the specific asynchronous magnet rate might not be the same as the pacemaker's programmed lower rate limit, could be faster, or in some older devices or those nearing battery depletion, it might even be slower than expected. In fact, observing an unexpectedly slow asynchronous rate upon magnet application can sometimes be an important diagnostic clue, indicating a low or depleted battery, signaling a separate problem that needs attention.
Okay, now for the absolute critical distinction. What about the magnet response for implantable cardioverter defibrillators, ICDs, or those common combination ICD plus PM devices? This is where that major potential for hazardous confusion lies, if not fully grasped.
Yes, this is arguably the single most crucial point regarding magnets that must be understood crystal clear for patient safety, especially in the OR or emergency settings. For an ICD, the primary effect of applying a magnet, again, if it's programmed to respond, which most modern ones are, is that closing the internal reed switch suspends all antitachycardia therapies. It turns off the device's ability to deliver both ATP and high-voltage shocks. This means that while the magnet is correctly positioned over the ICD, the device cannot shock VT or VF, even if those lethal rhythms occur. Therapy is suspended until the magnet is removed. However, and this is the vital distinction from pacemakers that must be absolutely ingrained, magnet application will not typically suspend rate modulation on an ICD. A programmer must usually be used to turn off that mode if needed. Furthermore, older ICDs that had only very basic backup pacing functions, for example, VVI pacing after a shock, will not convert to asynchronous pacing with magnet application. And critically, even with the newer generation ICDs that incorporate sophisticated dual-chamber pacing capabilities, essentially a full pacemaker combined with the ICD, applying a magnet will only suspend the shock therapy. It will not force the pacing function into an asynchronous mode. The pacemaker part continues to operate in its programmed synchronous mode, like DDD or VVI, potentially still being inhibited by EMI, even while the shocks are turned off by the magnet. This is the dangerous disconnect that can occur.
Wow. Okay, that is a massive difference with potentially lethal consequences if misunderstood. To make absolutely sure we truly grasp this critical distinction, let's walk through those clinical scenarios again, the ones illustrating these differences in magnet application and practice. These real-world examples can really solidify the understanding for everyone aiming for that mastery.
Good idea. Let's revisit those. Consider example A. A patient is a pacemaker-only device. During surgery, significant electromagnetic interference, EMI, from cautery is inhibiting the pacemaker's function, causing the patient's heart rate to drop dangerously low because they are pacemaker dependent. In this specific scenario, correctly placing a magnet directly on the pacemaker device should, if programmed correctly, immediately initiate asynchronous pacing, overriding the inhibition and restoring a safe heart rate. This is the ideal intended response for magnet use on a PM-only device facing inhibition.
Okay, so magnet on a PM-only device can potentially fix EMI inhibition and restore pacing. Got it. What was example B again, involving an ICD?
Right. Example B involves a surgical patient who has a combination ICD plus PM device. Based on preoperative planning, a magnet has been precisely positioned and secured over the ICD generator, specifically to temporarily disable its anti-tachycardia, shock therapy, during the use of high-risk cautery. Now, imagine that despite precautions, this patient suddenly converts into ventricular fibrillation, VF, during the surgery, a true life-threatening rhythm. In this case, the correct immediate action by the anesthesia team would be to remove the magnet. This action allows the ICD sensing circuits, which were still active, to immediately recognize the VF, analyze the rhythm, and appropriately intervene by delivering a life-saving shock. Here, the magnet's role was purely to control the shock therapy during EMI exposure, not to provide any pacing.
And the third scenario, example C. This sounds like the most hazardous one if the magnet response isn't understood properly, because it really highlights the dangers of making incorrect generalizations about magnet use, especially with modern combo devices.
It is indeed the most critical example to illustrate why specific device knowledge is absolutely paramount and assumptions can be fatal. In example C, we have another surgical patient with a modern combination ICD plus PM device. However, in this case, no magnet has been placed over it preemptively. During the procedure, the patient develops a lethal rhythm, let's say VF again. The ICD correctly recognizes the VF, analyzes it, determines shock therapy is warranted, charges, and successfully shocks the patient back to a rhythm. But imagine the post-shock rhythm is now a severe bradyarrhythmia, maybe complete heart block at 30 beats per minute, and critically, for whatever reason, maybe programming, maybe post-shock threshold changes, the ICD's own backup pacing function is not kicking in effectively. Now, if someone on the team, perhaps thinking magnet fixes bradycardia, mistakenly places a magnet over the ICD at this point in an attempt to treat this dangerous slow rhythm, what happens? It will not initiate asynchronous pacing in this modern device.
This intervention, in this specific critical scenario, merely results in disabling the recently used shock therapy, which could be extremely hazardous if the patient were to revert back to VF, while doing absolutely nothing to treat the ongoing dangerous bradycardia. The magnet just turned off the life-saving shock capability and failed to provide the needed pacing. This starkly shows why you absolutely cannot make generalizations about magnet use, especially assuming it provides asynchronous pacing in an ICD.
That is a truly stark illustration. It perfectly highlights why specific device knowledge, confirmed by interrogation, and understanding these critical nuances are just paramount for safety. So the golden rule of magnets, what is it, really, given all these complexities and potential pitfalls?
The golden rule, the absolute mantra for any elite professional dealing with CIEDs, is this. Placement of a magnet on a CIED should never replace a thorough, comprehensive preoperative interrogation of the device. Blind magnet placement, based on assumptions or generalizations about how most devices work, can severely compromise patient safety. It is absolutely crucial to remember that A, not all CIEDs have similar programming or magnet responses, B, proper CIED function should never be assumed without verification, and C, even placing a magnet correctly or reprogramming the CIED does not completely eliminate the potential effects of EMI. It only mitigates certain responses. Vigilance remains essential. Therefore, direct device interrogation using the manufacturer-specific programmer remains the only truly reliable method for accurate CIED assessment and formulating a safe perioperative plan. Furthermore, purely from a practical standpoint, intraoperative magnet placement sometimes has disadvantages. The patient's surgical position might make it difficult to reliably position and secure the magnet directly over the CIED generator, potentially leading to intermittent contact and an unreliable effect.
Reprogramming offers more certainty.
Okay, so pulling all of this together, the device knowledge, the EMI risks, the reprogramming, the cautious use of magnets, what does comprehensive expert-level intraoperative planning and intervention actually look like for patients with CIEDs? What are the key checklist items?
All right, a systematic approach is key. First and foremost, as per standard anesthesia guidelines, continuously monitor the patient's electrocardiogram, ECG, and oxygen saturation, SpO2, from the beginning of anesthesia until the patient is safely transferred to recovery. That's non-negotiable. Second, specifically for all CIE patients, perform continuous peripheral pulse monitoring. This could be manual palpation using the pulse oximeter waveform reliably, or ideally, an invasive arterial line. This gives you a real-time indicator of mechanical cardiac output, which is crucial if pacing or rhythm issues arise. If any unanticipated CIE interactions do occur, like sudden pacing inhibition, inappropriate shocks, or rhythm changes coincident with EMI, the procedure should be temporarily suspended immediately until the source of interference can be identified, eliminated, e.g. switched to bipolar cautery, move the grounding pad, or definitively managed, e.g. confirm device reprogramming, apply maggot if appropriate and planned.
As mentioned, having direct visualization of the pulse waveform via an arterial line is highly beneficial for differentiating true arrhythmias from EMI noise and assessing hemodynamic stability instantly.
And in terms of having the right equipment and backup plans ready in the OR,
Absolutely essential. Always have a magnet readily available in the operating room, but only if the preoperative interrogation confirmed the device is magnet sensitive and its specific response is clearly understood and documented in the plan. Don't just have it in case without knowing how it works for that patient. Ensure the grounding pad for monopolar electrosurgery is placed as far away from the CIE pulse generator and leads as possible, while still being appropriately positioned relative to the surgical site to ensure effectiveness. Strongly encourage the use of bipolar cautery whenever surgically feasible and advocate for short, intermittent bursts of energy, especially with monopolar cautery. Have chronotropic pharmacologic support, drugs like epinephrine, atropine, isoproterenol, drawn up and immediately available in case severe bradycardia or asystole occurs that isn't resolved by pacing. Know where the specific device interrogator, programmer is located, and have the manufacturer's technical support phone number easily accessible in the OR. Ensure all standard emergency resuscitation equipment, including an external defibrillator with pacing capability, is immediately accessible and functional. If ICD antiarrhythmic therapy has been disabled, either by reprogramming or magnet, it is prudent to place external transcutaneous defibrillation pacing patches on the patient preemptively, usually in an anterior-posterior position, ready to be connected if emergency pacing or defibrillation is needed externally. And, critically, confirm that the device has been reprogrammed according to the agreed-upon preoperative plan developed by the multidisciplinary team.
okay, fantastic. We've meticulously navigated the preoperative assessment and those really intraoperative challenges. What about after the surgery is done? What constitutes essential postoperative care for a patient with a CIED, especially one who's been exposed to significant EMI?
Postoperative care is just as crucial, as problems aren't always immediately apparent. Any patient with a CIE who has undergone a procedure involving exposure to electromagnetic interference, particularly significant exposure like prolonged monopolar cautery use, must be carefully monitored postoperatively. This usually means continuous ECG monitoring in a PACU or ICU setting initially. If a magnet was used intraoperatively to disable shock therapy, it absolutely must be removed as soon as the risk of significant EMI exposure is over. Breegee, patient is out of the OR, cautery use is finished. And following its removal, a complete evaluation of the device's integrity and function must be performed via interrogation. Similarly, if any device settings were temporarily changed during surgery via reprogramming, the CIE must be thoroughly reassessed postoperatively using the programmer and then reliably reprogrammed back to its appropriate baseline preoperative settings. This step is absolutely crucial and cannot be missed. For instance, if rate modulation was disabled intraoperatively, that mode must be restored to allow the device to respond appropriately to the patient's own physiological needs as they recover and become active again.
And when is a full, formal postoperative interrogation specifically necessary? Is it needed after every single case involving a CIED or only in certain situations?
That's a good question. While institutional protocols may vary slightly,
Postoperative device interrogation is generally strongly recommended, if not required, in several key situations. After any surgical procedure where a monopolar cautery was used significantly, especially near the device. Following any large, invasive, or lengthy surgery, even if only bipolar cautery was used, due to the potential for other stressors or physiological changes affecting the device. Definitely following any documented or suspected intraoperative adverse event involving the device. For example, inhibition, inappropriate shock, rhythm disturbance. And critically, after any emergent surgery where a proper preoperative device interrogation could not occur, you absolutely need to check the device function and settings after the fact in those cases. Consultation with patient's cardiologist or electrophysiologist should occur postoperatively as necessary if there are any concerns about device function, programming, or the patient's clinical status. And without exception, all perioperative interventions related to the CIED, from the preoperative assessment findings and plan to any intraoperative reprogramming or magnet use, and the details of the postoperative interrogation and final settings, should be meticulously documented in the patient's medical record. This creates a complete, accurate clinical narrative for future reference.
Lastly, what if the worst happens? What if there's a clear CIED malfunction noted in the immediate post-op period, or during some other acute, unexpected emergency situation outside the OR and the patient is hemodynamically unstable? What's the rapid response protocol for a professional facing that crisis?
In the critical event of a suspected CIE malfunction during a hemodynamically unstable cardiac rhythm, like severe bradycardia unresponsive to pacing or VTVF without appropriate device therapy, immediate life support actions are paramount, following standard ACLS-BLS protocols. If external defibrillation or cardioversion is required, remember the crucial points. Transthoracic paddles or pads should be placed anteriorly and posteriorly if possible, but never directly over the implanted CIE generator itself to avoid damaging it. The lowest possible effective energy setting required to successfully terminate the arrhythmia should be used, partly to minimize potential transient increases in the heart's own stimulation thresholds, which could make subsequent pacing, either by the device or externally, more difficult. And as soon as the patient is stabilized, a full interrogation of the CIE is strongly advised following any external cardioversion or defibrillation event. This is essential to assess the device for any damage or malfunction caused by the external shock, to check its current settings and battery status, and to reprogram it if needed.
We have truly navigated an incredibly complex landscape today. The intricate world of cardiac implantable electronic devices is clearly defined by this rapidly evolving technology, the expanding reasons for putting them in, and just the increasing likelihood that pretty much all healthcare professionals, in almost any setting, will care for patients with these devices.
Absolutely. And despite the amazing sophistication of these devices, the ongoing challenges remain significant. The lack of complete standardization among different manufacturers, the incredibly variable programmability options, those diverse and sometimes counterintuitive responses to magnet therapy we discussed, and just the sheer pace of continuous innovation that often outstrips the development of robust, evidence-based guidelines. All of these factors continue to complicate perioperative management significantly. It really is a field that demands constant learning and adaptation.
What becomes crystal clear from our deep dive today, though, is the absolute necessity of not just having a basic understanding, but striving for a true mastery of CIED indications, functions, and potential pitfalls for anyone involved in patient care. But maybe even more than that, it's about consistently adopting a systematic, collaborative, and adaptable approach. Providing safe, efficient, and truly individualized perioperative care is the only way to ensure optimal patient outcomes in this population. It's honestly a testament to the dedication required to really master patient safety in such a cutting-edge, high-stakes field.
Well said. And as this technology continues, its relentless march forward, further miniaturizing devices, maybe adding more sensors, expanding their communication capabilities, it really does raise a provocative question for all of us involved in healthcare, doesn't it? What new frontiers will medical device technology explore next? And how will we, the human experts, continue to adapt our knowledge, our skills, and our systems to ensure patient safety without stifling that essential innovation? What's going to be the next great leap in balancing this ever-increasing complexity with unwavering clinical confidence? That's the ongoing challenge and excitement in this field.